All right, so today we're going to finish up our ENT stuff, only a couple slides here, and then we're going to lead into the Kahoot review for the first test. So this should give you some ideas about the kind of test questions that might come up on the exam. It'll give you some ideas about my thought process on things. We'll have some good discussions around that. Anyway, any questions from the last time that we met? I think everyone is on board. Feeling good about some of your over-the-counter medications, like your NSAIDs, like your acetaminophen. Fantastic. We're going to move on talking about corticosteroids, specifically in sort of realm, right? So what do corticosteroids do for us, as far as like, what therapeutic role does it fit in? Inflammation, right? What do corticosteroids do for inflammation? They decrease inflammation. How do they do that? Well, very similar to the cortisol that we produce in our body, they're doing the same thing essentially, right? So cortisol, if you remember, goes down into the nucleus of the cells. It will then change things like gene transcription. It will change things like protein production of a lot of these inflammatory cytokines and whatnot. Do you think this is a very fast process or a little bit slower process? It's a little bit slower, right? So again, these are going to be drugs that do not kick in immediately. They take a little bit of time, at least a few hours, before you really start to appreciate a lot of the effects we're going to see with this, okay? Not only that, but some of the more locally acting ones we're going to see here, they need to be used really consistently, and they need to be used for at least, say 2 weeks before you really find the full effect you're going to see with these, right? Because they need some time to kick in because they are working, very powerfully at the very top of the pyramid, so to speak, of how inflammation occurs, but they still take time to kick in, right? So as opposed to something like we talked about, some antihistamines, right? So like diphenhydramine, do you think it's faster than the steroids or slower? Much faster, right? Because if you're having an acute allergic reaction, giving diphenhydramine is automatically going to block those histamine receptors, so whatever histamine's already been released will then be blocked, right? Can't have this mechanism at that point. However, with something like a steroid, it doesn't do anything for the inflammation that's already happening, right? It just kind of prevents further inflammation from occurring. So because of that, you're going to find these are very powerful drugs. However, they're going to take some time to kick in, and they need to be used pretty consistently. At least the ones we're going to see, they get used for a long-term basis, okay? Other ones we're going to see get used for a very short course. So we'll see here in a minute, right? So again, they're going to be working on all sites of inflammation. They're going to be working on a lot of the white cells, try to decrease things like mast cell degranulation, decrease chemotaxis of immune cells to the site of inflammation, all these good things, right? So again, very good. However, we're going to find they also have significant side effects associated with them, especially the more systemic that we're going to be using these drugs. So first off, we have our nasal corticosteroids, right? So these are going to be corticosteroids we're going to be using directly applied to the nasal mucosa, right? So again, this is going to be better for patients who only have really nasal symptoms, or if the nasal symptoms tend to be a little bit more dramatic for them or more pronounced, it's better for them rather than if they were having kind of more systemic-wide sort of symptoms, kind of more all over sorts of things, right? Now, again, this is not going to be the full list of every single corticosteroids out there. We'll hit some of those as we get into other inflammatory conditions and things like that. But these are some of the more common ones you're going to run into. And namely, the biggest one that got recently moved over within the past few years or so to over-the-counter status was fluticasone or Flonase. Okay, so that's a big one you're going to find. And again, patients can now self-manage themselves with nasal corticosteroid, right? Which is good. More access to it is good in this case. Other drugs like beclomethasone, budesonide, flunisolide, mometasone, and then triamcinolone. Those are the big ones. Now notice, you can probably tell a lot of these are going to be nasal corticosteroids based off of the brand name, right? So Nasalide, Nasacort, Nasonex, right? This is important because you're going to find that most of these have an inhaled alternative as well that we use for, anyone know what condition we use it for? For asthma, for long-term asthma control, right? So as a very good example of this, Flonase, which you would assume to be the nasal form, is different than Flovent. Flovent is going to be for the inhaled purposes for asthma. This is a common mistake that people will screw up and get these drugs intermixed, right? So patients say, oh, I'm on Flovent, and then you accidentally prescribe them Flonase. And they're like, what the heck? I don't have seasonal allergies, I have asthma, or vice versa. So because of that, you want to make sure you look at the brand, and this is why it's always good to kind of go back to the generics, make sure you're referring to, okay, this is fluticasone nasal spray, okay? Harder to get that messed up than you were to say fluticasone, inhaler. Okay, that's different enough where hopefully that would kind of limit that confusion there. But again, don't get those mixed up. It's a common medication error we run into. So again, these are going to be good for allergic rhinitis, more vasomotor rhinitis as well. And again, they're going to help to decrease that inflammation. And again, it will take time, though, up to 2 weeks before you really see the full effects here. They also need to be used pretty consistently. It's not going to be something where like, hey, I see the pollen coming down, I'm going to go ahead and just give myself a little squirt and then I'm good to go. Like, they need to be used consistently. As soon as you stop taking them, they're going to stop working, okay? That's kind of the big thing with that. Those symptoms should come back right as much as severe as they were beforehand, because again, you lose that corticosteroid sort of effect. Make sense? Anyway, the big side effects to watch out for here, obviously epistaxis can occur due to this, things like septum perforation. Keep in mind, if patients have, say, damage done to the nasal mucosa, corticosteroids, what does that do to wound healing? Typically slows it down. So if anything, you may find some worsening of this. They have, any kind of septum issues, you may, avoid using this for those patients potentially. It doesn't come up all that too often. And of course, unpleasant taste can be seen because anything going into the nose can potentially go back down the back of the throat, and they can have some taste associated with that. Okay. Other than that, the nice thing about this is you don't see systemic side effects. Okay. It's going to be much different than we see with the oral or the systemic corticosteroids we're going to see here in a second. So no real side effects associated with it. Say, for instance, you had a diabetic patient, they can receive this no problem, versus if you were to give a diabetic patient some of these systemic steroids, as we'll see in a second, that can be problematic, okay? So just know the limited effect, very local, just working on the nasal mucosa, and that's it pretty much. We already went over kind of how to administer nasal sprays. Same thing goes, just like we talked about the azelastine, same thing works here, right? Okay, so as far as any contraindications, really nothing, as long as you're not allergic to the product itself, right? Don't have to worry about things like, overdose information at all. Really can't happen. Even if they give themselves, some extra squirts, no issues going to show up from that. And again, the information about how to administer is going to be just the same. All right. Now, moving on, we have a couple of the systemic steroids we're going to run into. Okay, this is not every single one you're going to run into, but these are a few of the select ones used very commonly for ENT purposes. Now, first one we have this Dexamethasone or Decadron, and so this is going to either be available orally. You can give it IV, you can give it IM. In fact, actually, one of the things we do for little kids, because they oftentimes need liquid medications, we'll use the IV form because it's much more concentrated than what the normal oral liquid is, and we'll put it in some cherry syrup and administer it to them. So that way they need less volume, and it tastes a lot better for them. They get most of that cherry taste rather than having it taste, the actual drug product itself. So use the IV form orally occasionally. Now you're going to see this being used for lots of allergic conditions. It's going to be used for things like asthma exacerbations. It's going to be used for any kind of autoimmune diseases where you're going to need large amount of corticosteroids to tamp down that inflammation. It's going to be used for lots of different purposes. So we talk about ENT, but it's going to come up again and again, especially with a lot of rheumatologic conditions, as we'll see later on. But looking at these side effects here, you're going to notice there's quite a few, right? So again, there's a lot of systemic side effects because if I'm administering it IV orally, you're going to see a lot of those systemic side effects versus those just in the nose. So for instance, looking at, and again, we can know that this is going to have corticosteroid actions just like cortisol does. We can guess why some of these side effects are occurring here. So looking at CHF, looking at the hypertension, the fluid retention, why do you think that is? Why do you think this is causing you to hold on to more fluid?
Sugar, so it's going to draw that gradient?
It's a good thought. Not quite the mechanism we're looking for here, though. So remember, we talked about how when you have steroids, you have the glucocorticoid effects, right? Which kind of relates back to glucose and homeostasis, or metabolism. You also have what are the other one? Mineralocorticoid effects, right? And that dealt a lot with fluid retention and things like that, right? Remember, aldosterones are big, like mineralocorticoid we talked about. So you're going to find there's a blend here with these corticosteroids. They're going to have some glucocorticoid effects. They're going to have some mineralocorticoid effects. From this regard, the mineralocorticoid effects are going to cause them to act similar to aldosterone. They're going to cause us to hold on to more fluid. That's why you oftentimes will see a lot of patients when they get put on steroids, they're going to gain some weight. They're going to put on some fluid. And if they were already in a state where they're going to become edematous anyway, just due to their disease process, this can be worsened. So for instance, CHF, they have a lot of vascular congestion because their left ventricle is not pumping that well. You're going to find they're going to put on some extra weight, put on some extra fluid due to that mineralocorticoid effect, right? This can also worsen hypertension just due to the fact that you have a lot more volume filling up the tank, so to speak, filling up the vessels, and so that's going to increase pressure as well, okay? So if you have a hypertensive patient, this is only going to get their blood pressure a little bit worse based on that, okay? Yes, sir?
So would we want to use the systemic, so for the nasal?
Good. So that's a good question. When would you want to use systemic corticosteroids versus just the nasal? The nasal stuff is good for long-term control, right? So this is going to be good for, if I have a patient who I know they're going to have seasonal allergies and the season's coming up, they can use it for that period of time. That's good, right? Or they're going to have year-round symptoms. Say they have a dog in the house and they just can't give up Rover, and always know they're going to have nasal symptoms. That's great for them, right? Because it limits a lot of the systemic side effects. These systemic ones are a lot better for short courses of use, right? Now, if you have an autoimmune condition where you're going to be dealing with that the rest of your life, you may see some cases where you want to give more long-term systemic corticosteroids. typically when you're dealing with ENT complaints, when you're dealing with things like asthma, we'll talk about that in pulmonology, these are going to be for short courses, okay? So we'll talk about the dosing here in just a little bit as far as how we're going to be administering it. But typically shorter courses for this, usually for like kind of acute exacerbation. If you just need something just to kind of knock down the inflammation pretty quick, and again, systemic is going to be working faster within a couple hours versus the nasal stuff. That's good for that, right? But anyway, going back to the glucose intolerance, this is why it may not be a good option for your diabetic patients, because due to the glucocorticoid effect, what's it going to do to your blood sugar? It's going to raise it up, right? Because again, this is a stress, acting similar to a lot of the stress hormones you have, like cortisol. It's going to raise up blood glucose, okay? So again, diabetic patient is uncontrolled. They're going to have their sugars worsened by that, right? Even if they are well controlled, they may have to do things like adjust your insulin dose, right? So if you had a type 2 diabetic, they're insulin dependent, and they get put on, say, a short course of steroids, they may need to adjust their insulin dose up in order to account for that, right? So these are things you have to consider when you're dealing with these different types of patients, okay? Other things you can see are going to be things like hirsutism, can be related back to the steroid effects we see with that kind of Cushingoid sort of effects there. And of course, due to the fact that it's kind of working a little bit like aldosterone, it makes sense why you're going to lose potassium but hold on to sodium, right? Again, that's how you're getting those mineralocorticoid effects where you're holding on to all that fluid, right? And again, things like tendon rupture could be a possibility. Now note that some of these effects are going to be more related to more long-term sort of use versus just a short-term use, right? So if I were to give you, say, 5 days worth of Decadron, yeah, your blood sugar is going to be affected, right? Yeah, we're going to see things like, maybe some extra fluid retention. Are you going to grow all kinds of new hair because of this? Probably not, right? It's going to be more of kind of a long-term sort of thing there. So some of these things are going to be more kind of limited in scope. Some of these are going to be more seen with the kind of chronic long-term sort of use there, okay? Other patients you want to be careful of, if they have glaucoma, if they have increased intraocular pressure, this can increase that as well. So watch out with that. And then typically when you're on long-term steroids, especially, you're going to find the immune system is going to be knocked down. You can be more prone to infections, right? So again, this is an immunosuppressant, especially in long-term sort of use here. Typically, when you're given just a short 5-day course or something like that, it's not going to be as big of a concern. But certainly, if you had someone who was already immunocompromised to begin with, this can then worsen that, okay? So again, watch out if you're giving this with things like diuretics. The diuretics help you to lose sodium and help you lose potassium. This can worsen that. Look at interactions like with macrolides, right? We know macrolides are going to be CYP inhibitors. Well, this is going to be partially metabolized by CYP3A4, and you can find that the half-life is going to be extended. Yes, sir.
Is the suppressing the immune system the reason why it's getting into autoimmune disorders?
Absolutely, yes. Yeah, so we use a lot of corticosteroids for autoimmune disorders because, again, the body's reacting against itself. And so by tamping that down, by trying to push down the inflammatory response, that's why we can use it for those things like rheumatoid arthritis or psoriasis, different things like that, right? Any kind of immune condition, we will oftentimes use steroids. Either we'll use like bigger doses for like a flare-up, or we'll use a kind of more long-term kind of low dose in order to help keep things at bay, so to speak. Yeah, that's exactly why we do that. Again, decreased effect of anti-diabetic drugs. What do you think that is? Is raising blood sugar while your other anti-diabetic medication trying to lower blood sugar, right? So again, they're going to be opposing each other, right? And then again, be careful with patients with cardiac history, especially if they're prone to dysrhythmias. Again, this is going to lower your potassium, very similar to what we saw with aldosterone back in physio. So you have to be careful with that. It could exacerbate some of these arrhythmias. Okay, so a lot of these things will make sense. Some of these drugs we have not gotten to talk about in depth yet. So things like diuretics, I'm not going to ask you which diuretic is this most likely to interact with. That's not really where we're at this point, right? Now, however, when we get to hypertension, certainly that'll come up. But just know that things like, obviously electrolyte disturbances can be coming about from this. Know that glucose is going to go up, fluid retention is going to happen here. So those are kind of the things you want to key in on. If the patient already has a systemic fungal infection, obviously this would not be good because, again, you're tamping down the immune system. So if they have a fungal infection, they probably already had a bad immune system to begin with, so you wouldn't want to worsen that. Okay. Now, other things to note. Now, has anyone ever seen like a Solumedrol dose pack or a Medrol dose pack? What do those look like as far as like the dosing goes? Or do you notice anything about like the pills you're taking from day to day? Take like a bunch on day one, take like 5 or 6 on day one, and it's going to, so if you ever look at it, it looks like a little stepwise decrease, right? That's called a tapering dose, right? Where you take the biggest dose on day one, take a smaller dose on day 2, 3, 4, 5, and then you're off. Okay. Now, why do we taper those doses? How do we lower? Yeah, so it's lowering the doses you're going, but why do we do that? Why do we care? to not shock the adrenal glands. That's exactly why they do that. Okay, so the question is, well, do you need to taper? Because the idea is if my adrenal glands, they're working normally, right? It should be secreting cortisol at a pretty steady amount, right? If I were to give the body exogenous corticosteroids, what do the adrenal glands then want to do? They're like, hey, I'm on vacation. I don't have to do anything. I don't have to secrete these cortisol. I don't have to do anything. I'm good to go. So you're going to find you have adrenal atrophy that occurs because of that, right? So what happens when I take them off of the steroids? Does the adrenal gland like come right back and say, all right, here we go? No, it's going to take some time for that to really kind of kick back up. So if you're on long-term steroids, you cannot have the patient just stop their steroids altogether because they will go into adrenal crisis. Blood pressure is going to go out of whack. Their blood sugar is going to go all over the place. It's not going to be pretty for them, right? So this is why you have to be really careful with using long-term steroids, systemic steroids, I should say, because the adrenal glands need time to ramp production back up, okay? This does not mean that every single patient you put on steroids needs to be tapered. The key here is they're on less than a week long of therapy. That is not enough time for the adrenal glands to really atrophy to the point where you're going to worry about adrenal insufficiency, okay? If it's more than a week, then you want to consider doing a taper. So, but what a lot of people did for a long time was use those Solu-Medrol dose packs where they automatically build the taper in, and so they just use that forever. So a lot of people think that you have to taper off of every corticosteroid dose. You do not, right? You can, as long as it's less than a week, you can just take them off of it and they're good to go.
I wish you had told me this earlier, just because my dogs was on Decadron and I just abruptly took him off it.
How's he doing?
He's doing good.
Yeah? Was it less than a week? Was it less than a week?
To be honest, it might have been like 2 to 3 weeks.
Okay.
Like a weird spasm.
Uh-oh.
So, yeah, they put him on. They wanted him to like stay on these corticosteroids. So, but they're expensive. These meds are expensive.
Well, yeah.
Dogs, so.
Well, doggy steroids can be a little expensive. Now, I will be the first one to say I'm not an expert in veterinary medicine by any means. So who knows if the canine physiology is different such that you don't have to worry about that sort of thing. Who's to say, right?
I probably would have like cut it in half a pill.
I just right.
Like, no more.
Yeah, basically, yeah. So anyway, I will tell you though, last night, so I was on call last night, as I mentioned to a few of you, and the specialist called up and she was like, hey, so I got this veterinarian, and I was like, listen, don't bring me any kind of vet stuff. I don't know anything about, like, I know, don't give dogs chocolate, and that's like the extent of it, right? But I know the veterinarian tried to kill it themselves. It's like, oh, okay, no, this is good. I can deal with human physiology. I mean, not good for them, but, you know, it's like, I can work with that, right? Anywho, anyway, so again, be careful with that. If it's more than a week, you have to taper off. If it's less, you don't have to worry about it, right? You may find some old school practitioners who say you have to taper every single patient. You don't, okay? If it's less than a week, you're fine. But again, watch out for the immune system. Again, they may be more prone to things like viral infections, bacterial infections due to this. The longer time that they're on it, the more suppressed their immune system is, the more likely you are to run into that, okay? Another one that you're going to run into quite commonly is going to be prednisone, and then there's also prednisolone. Now, prednisone actually in the body gets converted over into prednisolone, so it's almost like a prodrug, like I mentioned before. However, usually when you find prednisone out there in the real world, it's going to be in a tablet form. Typically, the liquid form, which we'll use for pediatrics, is going to be the prednisolone. So if you ever see that, or if you had to like write a prescription for it, prednisolone's a liquid, prednisone's the tablets you'd be prescribing for those patients. Okay. Again, this is going to have very similar actions to the dexamethasone as far as side effects go, as far as monitoring goes, as far as all that good stuff goes, right? Only difference is going to be things like potency. It's going to be things like the duration of action. So for instance, if I have a patient who comes in and they need to have, say, a 5-day course of therapy with steroids, for prednisone, I may have to give that once a day or twice a day for that 5-day period. The difference with dexamethasone, it has a much longer half-life. And so I may only give a dose on day 1, and then I can give a dose, say, like 36 hours later, and they're actually still covered for that full 5 days. So those are some of the differences you're going to run into. So in this instance, dexamethasone has a longer half-life than prednisone. I have to give it less frequently, and it's probably going to be a little bit more potent than this. But again, look at your dosing recommendations when you're pulling this stuff up. Make sure that you're dosing appropriately based on the actual steroid that you're using. Okay. So anyway, same sort of indications you're going to see with this, same onset of action, same everything, right? Of course, you may be asking, like, well, why would you ever give prednisone versus dexamethasone? Honestly, prednisone has been around for a very long time, and we have a lot of good evidence for its use, but dexamethasone is starting to get a little bit more popular from that regard. So for instance, as far as like asthma exacerbations go, like almost everyone got put on prednisone. But now we're starting to find some evidence where, like, well, I can just give 2 doses of the dexamethasone. They're covered. They have the same kind of clinical effects as with the 5-day course of prednisone twice a day. So you find things will evolve over time, but those are the main differences between these different steroids here. Okay. Again, all this is going to be pretty much the same as you can see with this. Again, if you have patients who are on this long term, again, this is not for typical ENT stuff. They're going to be on for like 5 days or less. But again, if they're on it long term, again, consider them like an immunocompromised sort of individual. Okay. So for instance, in this case here, we say avoid live vaccines. When I say live vaccines, what does that mean? Yeah. So attenuate. Say attenuated. What does attenuated mean? Right, so they're a weakened version of the virus or whatever happens to be. So because of that, we don't like to give the weakened live ones to immunocompromised individuals because we run the risk of them not being able to fight that infection and actually cause the actual disease you're trying to treat in the first place, right? So just be careful with live vaccines in immunocompromised individuals, especially those from long-term steroids, okay? We'll talk more about immunizations in the next semester, but just kind of be aware of that. Okay, so let's get into some decongestion. First off, we have Oxymetazoline or Afrin. Haven't seen Afrin before or heard of Afrin? Right, it's pretty common over-the-counter medications. A nasal vasoconstrictor, right? So if you have really stuffy, runny nose, like this can be a really good medication to help kind of deal with a lot of that congestion that happens right there. And again, this is a very locally acting sort of drug, but we're going to see that just because it's locally acting does not mean it cannot have systemic side effects. We're going to see here in a minute. Now, actually, this actually works a little bit like cocaine, because when you snort cocaine, cocaine typically is a vasoconstrictor. So actually, if you had a stuffy nose, cocaine would actually do the job. I would not recommend it though, but using something like Afrin is a good vasoconstrictor. And so if you had to think about which receptors are good about causing vasoconstriction, you would say alpha receptors, right? If I said beta 2, you'd say, no, it's usually vasodilatory, if anything. This is a good alpha agonist, which means it's going to be binding to those alpha receptors on the nasal mucosa. It's going to clamp down on them. And again, why do you get stuffy in the first place? Well, again, you have these very dilated vessels that are bringing all this fluid, and that's what's causing that edema, is what's causing that congestion is happening there. So by squeezing down on those vessels, you decrease the amount of fluid that's there, you decrease that congestion, you can see with that, okay? So very good for that. However, be careful. If you have patients, for instance, who have hypertension, not all of that drug is going to stay right there in the nose. You're going to find there's going to be some systemic absorption in these cases, in which you can actually find that uncontrolled hypertensive patients, they're going to have their blood pressure raised by this, okay? Or if they were on hypertensives, they're on under control, this is going to worsen. That's going to raise their blood pressure, okay? So be careful with that. Avoid in patients who already have hypertension to begin with, right? Now, if it's just kind of like a one-off thing, and it's like they just get a cold and they want some relief, like, yeah, you can use this. That'd be fine. However, on the other hand, if it's going to be more like I know all season this pollen's just going to really get my nose running, that's where things like the nasal corticosteroids are going to be a better bet for them. They're better long-term controller medications. This is better for short-term sort of use, okay? Now, again, you do not want to use this more than 3 to 5 days in a row, okay? You're going to have this constriction that occurs over time. And if you remember, what happens when you have these receptors that are constantly being activated for a long period of time? What do? They downregulate, right? So you're downregulating because they're getting hammered. They're getting activated. So you're going to have the alpha receptors start to downregulate, and there are going to be fewer of them there. Well, if you come off of this medication, it's going to happen. Anyone ever seen or heard about, or maybe on TV or something, like when someone runs out of cocaine, what happens to their nose? You get really sniffly, right? Because again, you lose that vasoconstrictor effect, and what happens? All of a sudden, you get those vessels, they open wide open, and you get this rebound congestion that was probably worse than the congestion they had to begin with. Okay, same thing happens with this, right? So you get that downregulation of those alpha receptors. You're going to find that once you take away that constrictor, now all of a sudden you're going to have those vessels, because they have less alpha receptors to respond to natural, epinephrine, norepi. It's going to open wide open. You're going to get the rebound congestion. We call that rhinitis medicamentosa. Okay, not good. It's not very comfortable for your patients. The only way to deal with it is to either give the medication back and then slowly taper them off, or tell them they're just going to deal with it until it kind of reverses itself. Okay, I knew one pharmacist who, there's like big long counters. They have like a CVS or Walgreens. He worked at one. He had 3 bottles of Afrin located at different points along the desk because he was so addicted pretty much to the stuff that he had to have a constant dose just to keep his nose from going crazy, right? So again, short-term use, do not use this more than 3 to 5 days. Okay. All right. And again, same thing as far as like administration. Again, remember to do like the opposite hand sort of things. That way you kind of aim it away from the nasal septum. Yes, ma'am.
Is that something they have like on the box? Like, so people, if it's over the counter and they just go in and they get it, do they know that?
That's the thing, is like, you can just go in and buy this stuff. There should be somewhere on the box, but that stuff's such a little print, and like, actually you can read that.
I just literally got it and I learned about this. So it looks for 3 days. It's on there.
Yeah, so perfect. Yeah, and a lot of times, like for instance, if we have to use it, because we'll use it for some of our ENT kids if they come in like for like actually this is good for nosebleeds too. So if you have cases of epistaxis, you can use this in order to constrict those vessels down and decrease the bleeding. So there's other uses for it. But yeah, so it should be there. But again, our patients are guaranteed to actually read the bottle or read the box. Probably not, right? You know, it just depends on what the situation is, and they could be stuck with it for a good long time.
Now, sorry to have you go back a couple slides.
Oh, how dare you!
Quick, prednisone.
Yeah, what's up?
Prednisone and
Prednisolone?
Which one?
Prednisolone? Oh, dexamethasone. Okay.
Yeah. You said that prednisone has a higher half-life or a lower half-life?
Shorter half-life than dexamethasone. And again, I'm not gonna. I wouldn't ask you on a test this early in. You know, which one has a longer half-life, dexamethasone or prednisone? Like, I don't really care that you know that specifically.
I just wanted to know because that's the drug I use in urgent care, so it's really curious. Thanks.
Yeah, there you go. So anyway, right. So again, Afrin, bad for hypertensive patients. Again, use it for short courses. In fact, in our in Epic, our electronic medical record system we have at the hospital, because we'll use it sometimes for like ENT complaints or things like that. We have a hard stop, so that way the nurse the order will fall off the chart after 3 days. So that we cannot use it too long. The nurses won't have an order to go off of, even though the medication might still be around, right? Up next, we have Pseudoephedrine or Sudafed. Okay, so what is Sudafed notorious for? Some of you knew that a little too quick. No, right. So you can use Pseudoephedrine. You guys are familiar with Breaking Bad? Very good show. You can use Pseudoephedrine to make methamphetamines. Okay. Again, I don't know the full recipe, so you guys have to go somewhere else if you want to learn that. But because of that, due to the risk or due to the perceived risk of all these people going around and making all this methamphetamine, they decided to put it as a behind-the-counter sort of medication, right? So again, for a while, all you had to do was like come in, you just sign a little log, and then you can just get the Sudafed that you needed from the pharmacy or behind the front counter, wherever they kept it. But nowadays it's all electronic, right? So now they can actually monitor to make sure that you're not going from CVS to CVS to CVS or Walgreens to Walmart to wherever to pick up all the Sudafed, right? So they hard cap you at how much you can actually get per month, which is bad for some patients because they really do benefit from it. They really need it. And for most patients, it really doesn't matter, right? It's just more of a hassle of having to find someone to actually get it for you rather than just picking it off of the shelf, right? Now, does that mean all Sudafed products are behind the counter? I mean, if you go to Walgreens, you still see Sudafed on the shelf. So what's in that? Heard it. So it says Sudafed, and there's 2 letters after it. PE. Don't buy that stuff. Don't ever recommend that stuff. It's no good. If you really need a decongestion, don't recommend that because it has phenylephrine in it. Because they wanted to market something, they at least keep it on the shelf so that way people are still buying their product. You see Sudafed, you think it's Sudafed. It must be good, right? Because of that, it is a very wimpy sort of vasoconstrictor. Sudafed is going to get pseudoephedrine, legitimate pseudoephedrine, is going to have a lot better vasoconstrictive effects than you would see with phenylephrine. Phenylephrine it can be a very good drug, especially when using an IV. We use that for blood pressure support quite frequently. However, pseudoephedrine from an oral ENT sort of standpoint, like this is where you're going to get the most benefit. Yes, ma'am. Phenylephrine. So it's kind of like it's just like the wimpiest version of all like your catecholamine. So like, you think epinephrine is being kind of the gold standard. Phenylephrine is like its little brother or something, right? Just doesn't really do the job like pseudoephedrine does. So anyway, but again, it's an alpha agonist, right? This is as opposed to Afrin, which we're going to be using nasally to work very locally. Sudafed is going to be a oral product, which means it's going to be working systemically, right? So again, for those hypertensive patients, this is also going to be causing some vasoconstriction. You're going to see blood pressure go up when patients are on this, okay? Be really careful. Does anyone, and this is a trivia point, does anyone know what this could show up as on a urine drug screen? Amphetamines. It actually shows up as amphetamines because it is a precursor to that. But so again, it's one of those things where you may get asked all kinds of weird questions by your patients. They go, "Oh my gosh, I got a drug test coming up. Here's my medication. Is anything going to show positive on here?" You say, okay, you take Sudafed, right? But you have to ask about it because over the counter. But Sudafed could show up as amphetamines, right? And so that's good to know because if I had a urine drug screen done and it came back positive for something that I had no business doing or had no history doing, I'd be pretty concerned, right? So someone came up like, you were doing amphetamines. I'm like, no, I'm pretty sure I'm got my teeth still. I don't think so. So there's things you want to be aware of, right? Little things like false positives on urine drug screens and things like that. But anyways, this is good for relieving a lot of that congestion, but be careful because of the fact that while there's a very good decongestion, you're going to find it's also going to raise that blood pressure, and that can be a big concern for a lot of patients, right? We have a lot of hypertensive patients out there. And again, what other effects might you expect to see? Well, certainly things like tachycardia can develop due to this. Headaches, due to that cerebral vasoconstriction, like all of those things can potentially cause side effects due to that hypertensive sort of nature to it, right? Okay, and again, don't use this stuff. It's really, I thought I put like a big circle on that line through, but I did not do that, but that's okay. You know not to use it, right? Yes, ma'am.
If it works like Afrin, do you still get the rebound or no?
You don't really get the same rebound. You may find some limited rebound if you're using it really consistently for a long period of time, but not to the same like really significant effect that you see with Afrin. Because again, Afrin's just like everything's just locally right there versus Sudafed working kind of more systemically. Yeah, that's a good question though. Anyway, finish up with some antitussives and expectorants. An antitussive does what? Prevents you from coughing. What's an expectorant do? That's to cough stuff up, right? So all that nice thin gunky mucus you're going to get down in your lungs. It up. Now again, with cough, you're going to find there's cough receptors that are located all the way out through the respiratory tract. They can respond to several things, right? It could be chemical irritants, there could be mechanical irritants that can cause this. And again, there's a whole really complex cough pathway that helps to regulate all of that. And actually, you can get really strong pressures and really high speeds of the materials coming out. So I don't know where they actually got this, and of course I didn't double check to make sure it's accurate, but 500 miles an hour sounds pretty crazy. I'm pretty sure if I coughed right now, I could probably hit most of you in the back of the room. So I'm not going to try that, but it could happen. Anyway, oftentimes, why can cough be bad? Why does that be a problem for patients? It's uncomfortable, right? What else? Yeah, so you can see, yeah. So you can see that. I guess it happened maybe to somebody, but right. But I mean, there's been rib fractures that have happened from excessive coughing. Dysrhythmias can be induced by this. There's lots of problems with it. So typically, and we have a lot of over-the-counter medications. We have some prescription products as well, which I'll mention, that can be used to help kind of reduce either the number of coughs, severity of coughs, hopefully to prevent any of those complications from occurring here. Right now, does anyone know a common antihypertensive that routinely causes cough in patients? Now, actually, yes. I'm sorry, you're right. No, I was going to say that was wrong, but yes, lisinopril is a big one, right? So I was ready for no one to actually know the answer, and I was like, I got you. But anyway, yes, ACE inhibitors. ACE inhibitors are a big one, right? So I had one of my cousins, he's hypertensive, and he got put on a like lisinopril or something similar in that family, and he was just all the time just coughed, this dry, naggy cough, couldn't get rid of it, and they're finally like, it's probably the medication he's on. So I switched him over, and we'll talk about it when we get to hypertensive stuff, but if you go to an angiotensin receptor blocker, that eliminates the cough for the most part, right? So just a little tip, we'll cover that again later on, that won't be on the test by any means, but lisinopril and other ACE inhibitors cause this kind of dry cough. But anyway, so again, there could be drug-induced causes for a lot of these things too, not just complaints. Now, this first drug we have here is called Benzonatate, or Tessalon. It's Tessalon pearls. This is actually a prescription product, so you can't get it over the counter, but it can be commonly used for cough as an antitussive agent. Now, these probably go down in history. You notice they call them pearls because they kind of look like little tiny pearls. These go down in history as being the #1 most difficult thing to get from the big bottle onto my little plate here, so I can count to 30, into the small bottle. They go freaking everywhere. So, I mean, if you go to most pharmacies, there's probably Tessalon pearls kind of like all over the floor somewhere because they just roll everywhere. Anyway, some of the big practical skills we got in pharmacy school is how to take things from big bottles, put them in little bottles. But anyway, so this is actually kind of interesting because it. Oh, yes, sir.
Also, with benzonatate,
yeah.
The only bad thing about it, I mean, from your perspective, like it kind of numbs your throat, but then later on, when you like all that gum fills up in your chest, and you have like a wet cough, and it just like exacerbates it.
Right, so it depends. I mean, like some people have more dry coughs that develop. Some people develop more of those kind of really wet, like just really congested sort of coughs. We'll have different medications we can use for that. Often, what I think is kind of funny is if you look at a lot of these over-the-counter products, they're oftentimes mixing an antitussive plus an expectorant. An expectorant, we said, it helps you cough stuff up, but then I'm giving you something to blunt your cough. Like, it almost seems like they're fighting each other, right? So you see a lot of products like that. I usually don't recommend those for anyone. Really try to do with either one or the other. If you're coughing because you got all this junk in your lungs and then cough it up and then use something to help you cough it up and then you don't cough anymore, right? As opposed to, if it's something maybe like some postnasal drip or something like causing cough, that could be a different thing, right? Maybe you want something more drying. So for instance, my little girl, she's just got sick recently, and she just really runny nose and stuff like that, and really her only main symptom she was developing. But the problem is she's getting those postnasal drip that was hitting the back of her throat. She started gagging and then she throws up. Right, no gastrointestinal issues, so to speak. It's just that gag reflex gets hit with that. So because of that, like, she actually would benefit from a drying sort of agent. What's something that can dry up secretions? We talked about. And histamines, yes, we give her some Benadryl. Also helps knock her out a little bit so she can sleep a little bit better, and hopefully she doesn't throw up in the middle of the night, right? I can tell you right now, there's absolutely nothing worse than trying to clean up a bunch of sheets and stuff in the middle of the night after someone has thrown up on them. Or maybe some of you experienced that, but it's not fun when it's your 2-year-old. Anywho, so anyway, the benzonatate, this is going to work by actually anesthetizing a lot of those cough receptors, right? So what's actually interesting, though, is you do not want to chew up this little capsule. Because if you chew it up and it gets on your tongue, guess what happens to the tongue? It gets anesthetized too. Yeah, so you get this like kind of oral numbness that can develop from this. So not usually recommended, but by ingesting it orally, it's going to be able to get absorbed, and then you get those cough receptors actually anesthetized. And so even though the irritants may still be there, it actually is going to be blunted. That response doesn't get sent up to the CNS, and then you don't have the cough, that urge to cough, as the case may be. So those are the big things to watch out for, and actually be careful with little kids getting into this, because again, what do these look like? Look like candy. So little kids get into this. Actually, that numbing effect can actually work more centrally on them and actually cause pretty significant sedation, right? So I've actually seen some kids actually need to be intubated after they got into a bunch of Tessalon pearls, ate a bunch of them, and they had this respiratory depression associated with that. So be careful with these, obviously.
So when it comes to like antitussives and like expectorants, I used to work in like a home office, and like the providers there were like, they were very against like using these things because of like your body's like natural responses to like cough. So like when it comes to like this stuff, like when you know to like prescribe it or like.
Yeah, so that can be tough, right? Because again, if you're producing all this mucus, there's some kind of irritant that your body's obviously like secreting mucus and whatnot to try to get rid of. Like you probably want to get rid of it, right? So again, I might recommend it more for like kind of like drier, more like hacky kind of coughs, where they're not really like they're really non-productive sort of coughs, and if it's just like really just a negative quality of life sort of thing, like if I was coughing all the time, my wife was like, "I'm gonna kill you if you don't stop coughing." I was like, "Oh, I'll take some Robitussin, right? I'll take something to try to prevent this." It just depends on the situation, right? But again, if they have a truly like infectious cause for that cough, then you probably want to get rid of that stuff, right? Because again, the lung should be a sterile environment for the most part, and in most cases, like to limit the use. So again, short durations of use, because if you use it for long periods of time, like there could be something else really going on there that you need to identify the reason why they're coughing so much, right? So again, you can mask a lot of these symptoms by self-treating, which is why these over-the-counter stuff can be dangerous in the wrong hands, right?
Yeah, because they were saying like it was like an asthma clinic, so a lot of people would come in with like an exacerbated response because they were like suppressing their cough, and like everything kept staying like inside, and it just kept getting worse. So I thought they were like making it better.
Yeah, and again, they could just be masking symptoms, right? So again, that's always the question. And that's why they usually will say like, hey, don't use this more than 2 weeks, don't use it more than 10 days or something, or if symptoms continue, then go see a healthcare provider, right? That's always their out that they'll have on all those packaging that says like, hey, this is not for long-term use. You should go and see a provider about this, right? So again, and everyone's perspective is a little different. So in that perspective there, with as far as like dealing with the asthma population, yeah, they probably saw there was a lot worse effects because they were trying to, get through those asthma symptoms by treating the cough when that really wasn't the issue, right? So to speak, like the asthma was the issue with that, I suppose. Does that make sense? Hopefully. You seem unconvinced, but that's okay. We can talk later. Okay. Anyway, so another antitussive agent that is quite frequently used is going to be Dextromethorphan, otherwise known as Robitussin, or Delsym's another common brand name for that one. Delsym usually comes like a liquid formulation. Does anyone know I put Bender the robot on here? Nobody? Did you know? People can drink it to get high. Does anyone know what you call it? Robo-tripping. Thank you. I knew someone would know this. Okay. I know who would know it, but I knew someone would have heard of it. Yes, I'll talk about robo-tripping in a second. But basically, dextromethorphan is kind of interesting. It's actually a relative of codeine. Codeine, does anyone remember what that is? Or anyone know? It's actually an opioid medication, right? So we use it for like analgesia. Actually, what's interesting about the opioids, all of them have antitussive effects, right? So morphine, heroin, any opioid could have antitussive effects, right? They help to kind of blunt that cough response that happens within the CNS. Now, dextromethorphan itself does not actually act as an opioid, even though it's a cousin of codeine. So it doesn't really get the same pain relief that you would see with an opioid, but it does help to still suppress that medullary cough center, right? So it works the same as codeine would. However, it doesn't have the same analgesic effects. Okay, so you would think, okay, well, no one's going to abuse that. Like, it shouldn't have any problem. Well, actually, people do abuse it. I'll talk about why in a second. You have to be careful with it. Obviously, the indication will be for cough, and it's good for kind of mild self-treatment for that. And again, be careful. If someone comes in, they say, "Oh, I take Robitussin." What's the next question you should ask? Are you robo-tripping? Yes. And they say, no, but that elephant I see in the corner is no. The question is like, well, specifically, which Robitussin was it? Because again, Robitussin is one of those ones where they put their name on every single different product they have. Someone could have antihistamines in it, someone could have Tylenol in it, someone could have all kinds of different products, and you need to be very specific. So just saying I take Robitussin doesn't really tell you a whole lot. It tells you there's a family of drugs it could be, but that's why it's really important they can look at the packaging, or if it says specifically dextromethorphan, cough and cold, or something like that, they can give you a little bit more clue as to what's actually in there, right? And again, that's a frequent thing we run into at the poison center where they call in like, oh my gosh, my kid drank all the Tylenol. It's like, well, what kind of Tylenol was it, right? You have to be more specific. If it's Tylenol PM, which has diphenhydramine in it, that's a whole different story than would be if it's just regular Tylenol by itself, okay? So again, these are questions you have to ask yourself, or as a patient. Anyway, so one of the things you see with dextromethorphan is actually that has these effects, and you can look this up if you're interested, although maybe turn safe search off to get the right results. But if you take a whole lot of dextromethorphan, you can get this sort of dissociative sort of high off of it, and they call that robo-tripping. So if you ever hear like little kids, or more often adolescents, I should say, getting into Robitussin, like that's why. Because again, this stuff is available over the counter. It's easy to get a hold of it. You don't need to show an ID to buy this stuff. If you take enough of it, you can get a pretty wicked high off of it from what I've heard, right? I hear like kind of lower doses is kind of like really harsh, but then once I get enough of it, I'm just gonna keep drinking it until I get to where I'm at. There's different planes of robo-tripping. It's very strange if you read any of these forums about it. But anyway, I do not recommend it. But if you heard someone come in like, yeah, they drank a whole bottle of Robitussin, that's probably why they did that. So you want to at least be aware of these sorts of things. What's interesting, they can actually have some of these kind of like these pro-serotonergic sort of effects. So if they happen to be on things like antidepressants that help to increase levels of serotonin, you can see some interactions there. And so you can see things like their blood pressure is going to skyrocket, their heart rate's going to go up. They're going to have this hallucinations that can develop from this, and they can be pretty difficult to manage patients. You have to oftentimes give them sedatives or things like that to try to calm them down, and kind of, especially if they have a bad trip, right? There's always the concept of having a bad trip. Some people have a really bad time with these sorts of drugs here. So just be aware. People can abuse pretty much anything. This is one of the ones you may see more commonly than just like abusing anticholinergics like chlorpheniramine or diphenhydramine. The same thing can happen with this, okay? All right. And then the last drug we're going to talk about here is going to be, we'll talk about opioids when we get into like pain management stuff later on. Just know any opioid has antitussive effects, but we don't frequently use it for cough, at least if we can avoid it if possible, right? Because you always worry about addiction risk. Last one we have here is guaifenesin. Oftentimes you see it like in Mucinex or in other products like that. This is purely a mucolytic, which, what does that mean? Breaks up mucus, and then it's going to be an expectorant as well, right? So again, it's going to have to break up the mucus, and it's going to help you to cough it out, essentially. Again, it's going to loosen the mucus, decrease that viscosity, which can be good. But the one thing to know as far as like patient education goes, drink a lot of water with this stuff, okay? So if you're going to take it, drink a lot of water, because usually when people are sick, they usually get dehydrated. That's going to make that mucus more thick and sort of tenacious. By having lots of fluid on board, you're going to have to hydrate it more, break it up better, and they can cough it out, okay? And again, really no side effects, very well tolerated sort of medication, so nothing else to know with that. I probably question some of the efficacy, but some people will respond well to it.
Is there like a mechanism of action with that other than it just fixes the viscosity?
Not necessarily that I'm aware of. It's probably one of those things where like we don't really know why it works, or at least that there's a good unifying theory. I'm not aware of it. Certain other ones, like there's certain drugs that will actually work to break down a lot of like the actual DNA within like some of the neutrophils and stuff that's in it that helps like decrease the viscosity. But I'm not sure for this one if there's anything specific we've ever come up with. But other than that, that is last one for that. I mean, just drink lots of fluids, and again, be careful. If patients are treating themselves for say longer than a week, they could be masking something else, right? They could have a pneumonia that's been developing. They're trying to treat the symptoms of it rather than actually getting what they need, which may be antibiotics, which may need other things. Okay, so just be aware of that. Any questions on that? So this is the end of the material for the test. Now, there were some concerns that were raised by multiple individuals about, well, we got these OSCEs coming up. We got this, what exam's coming up? No, it's with Professor Hilton. Yes. So anyway, so people were concerned, like, well, we haven't had optho, and so there might be optho on this, and they were concerned. It's okay. You've had optho in CMS. You know enough information to make it through that exam. So do not worry about that. You'll be fine. Again, you're not going to say, diagnose a conjunctivitis, and they say, okay, I'm going to give, I don't know, erythromycin to it, and they're like, well, why that? Well, is that dose right? Should you use this instead? They're not going to quiz you like that. They're not going to pimp you like I would like on an exam when I get to the optho stuff. So just be aware. Don't freak out about the optho stuff. Again, you've had it in CMS. You can do it in PD. You're going to be fine. Okay? Did I assuage anyone's fears? Nope. My lecture wouldn't have helped anyway, right? All right. So let's do a 10-minute break. We'll come back, and then we'll do the review for the test.